Is everyone, yeah, okay? Bonjour encore. Okay, so as Dr. Amber said, and everyone, there's a lot of information for you all to ingest, as well as the lovely food. But anyway, welcome back. Now, I've been asked to talk about risk management in the acute stage. And so I just want to share with you some objectives. I'm just going to have a little bit of an overview about respiratory, although Sue's doing the main respiratory. Talk a little bit about pressure area care rather, bladder care and bowel care. And I think basically what we must be mindful of is the massive psychological support that we need to be giving our patients, because this is a life-changing injury. So from an acute management point of view, patient presentation, as a healthcare professional, you need to be looking at the date of the injury, mechanism of injury, whether or not the spine is stable or unstable, whether or not there's any bleeding, what's the respiratory assessment, the bladder, bowels, neurological assessment, cardiovascular system. Looking also very importantly when someone is newly injured, whether or not there is any signs and symptoms of an ascending infection, ascending neurology, which could actually have huge implications on the respiratory system, especially if you have a high injury. So that's something to be very mindful of in the early stages. You also need to be looking at pain, as I say, psychological well-being, the joints, and any functional expectations, for example, as we've heard about. So what are the tools? What are the tools that we as nurses or any healthcare professional should use? It's not just about writing documentation. We need to be, and this may sound very simple, but actually we do need to remind ourselves that this is important. We need to be using our eyes. Do our patients look comfortable? Do they look safe? Do they look scared or in pain? If you're looking at, if you think about the bladder, is there catheter draining? Now that may sound very simple, but actually with someone who has a T6 and above level injury, they may well have something called autonomic dysreflexia. So something as simple as checking a catheter is flowing is really, really important, but we'll come on to that. So looking at touch, do they feel hot? Do they feel cold or clammy? Do they have an infection? Do they sound depressed? Do they sound in pain? Do they sound frustrated? Again, this is a life-changing injury, and part of the adaptation that your patients will be going through is going through that bereavement process. And that's normal, but we do need to be mindful of that and support people through that. Another thing is smell. Our patients are at risk of urinary tract infections. They are at risk of fecal incontinence. They may be at risk of having an offensive wound. So again, it's being mindful of all your senses. So important. And until you know your patient, you know the level of injury and the stability of their injury, please do not move your patient. If you do, you could be creating a complete injury, having been an incomplete injury. So you may be making it worse. So if someone asks you to move a patient, make sure you know and check the stability of the spine and the level and completion of that injury. From a respiratory point of view, we're going to be looking at the history, if there's any abdominal or paradoxical breathing, what type of airway management there is, are they on a ventilator, which you may not see over here, I'm not sure. But that would be with a very high level spinal cord injury, as Sue and Shiva have mentioned. And whether or not they are breathless, are they using a lot of exertion? Because if they are, they may well get very tired. And so is looking at other things like, are they cyanosed, are they using the accessory muscles, are they wheezing? And you'll be looking at their saturation of the oxygen in their skin, if they're on oxygen, what their respiratory rate is. And the key thing is, I know it in English, I don't know what you'd say in French, but C345 keeps the diaphragm alive, okay? Nice and simple, and that will really help you, okay? C345 keeps the diaphragm alive. The main risks that you'll face, as I said, is the neurology worsening because of the spinal cord swelling. You've got unstable fractures, the person's getting tired, there's risks of chest infection, aspiration. And Sue and Shiva have already mentioned about the high levels and the implications on the respiratory function. Again, Sue will go along this, but this is something that certainly people who are on the wards all the time, so specifically nurses and nursing assistants, will need to know how to do a cough assist. And I know Sue will be sharing that really, really important information, because unfortunately people may need to help to cough in the middle of the night, and that's when probably you don't have a physiotherapist on board in the hospital. So being able to know how to do assisted cough could save a patient's life, because if they've got a plug and they can't cough, then they're going to be in severe distress. So very, very important to know about that. From a pressure ulcer prevention point of view, now I know you've shared that a lot of your patients do have pressure ulcers here in Mauritius, and this is something that, to be honest, over 95% of pressure ulcers are preventable. 95%, all right. So that really, it's all about knowledge, it's all about sharing our skills and knowing how to prevent pressure ulcers. Now, something that I've found in the low middle income countries that I've worked in is that people want to do the best, but they don't know. They are worried that someone is in pain, they don't want to make that pain any worse. So that's why that person isn't moved. If you don't move, you are in one place all the time, you'll get a pressure ulcer, because it is an injury, a pressure injury. It's cultural beliefs. Some people say they'll use local medication first, and they may end up going to hospital when they have a massive, massive pressure ulcer right down to the bone. And I've seen them when you get 4 fists into a pressure ulcer of your sacrum. I'm sure perhaps quite a lot of you have seen that as well, unfortunately. And that has a lot of risks to our patients, and ultimately it does result in an untimely death. Malnutrition and dehydration, and that comes with poverty. It may be they're not able to get to food and fluid, but again, that has a huge impact on the skin. And if someone has a pressure ulcer, it heals. It may well, because they're so vulnerable, they may well develop another pressure ulcer. They may have the chance of having plastic surgery, but then again, you've got that vulnerability. You've also got prolonged hospital stays, you've got financial implications, and as I've mentioned, you've got the increased risk of morbidity, so that's infection, osteomyelitis. If you've got someone who is in bed all the time, isolated, they get very depressed. If you're depressed, you don't want to move, so you have that cycle going on. And ultimately, unfortunately, there is a very high risk of mortality. With spinal cord injury in low middle income countries, the majority of people may die within the first 2 years. And most of those is actually within the first sort of 6 months. And that's infection, infected wounds, infected urine and pyelonephritis being 2 of them, and also respiratory infections as well. Just a little reminder about pressure ulcers, and again, this is all about risk management, because we need to know what the causes are. And so you have extrinsic factors and intrinsic factors. Extrinsic factors, you're looking at pressure, you're looking at friction, you're looking at moisture, and shear. So, and one thing that when I teach my patients is, if you put your finger on your skin, and I know it's difficult when you've got slightly darker pigmented skin, but all you need to do to demonstrate what pressure does is you press your skin for a little while, take your finger off, and it's white. That means that there's no blood getting to that area. It's as simple as that, okay? So we do need to be mindful of things like the mattresses, collars, endotracheal tubes, nasogastric tubes, catheters, and so on. And our poor patient who has a spinal cord injury, as you can see, has many, many extrinsic factors. The intrinsic factors, so things that happen inside, is, again, it's mobility, medical conditions, age, dehydration, and malnutrition. And a lot of these things that we can address, but we need to be mindful that our patient with a spinal cord injury has many, many risks. So we need to manage those. We need to take pressure ulcers seriously. Now that is, pressure ulcers, it's a reflection of good care and bad care, I'm afraid. It's as simple as that. As we said before, over 95% of pressure ulcers are preventable. So we do, as healthcare professionals, take this seriously. And certainly in a lot of countries now, in the UK, in America, and certainly when I was living in Nepal and Haiti, we did audits every month about how many people came into hospital with a pressure ulcer and how many developed a pressure ulcer whilst they were in hospital. And we would do root cause analysis, say, okay, well, this person has developed a pressure sore. Why? What happened? What could it have been? Are they being turned? Are they malnourished? Are they drinking enough? Are they in pain? Have they got spasticity? All these things, if you can answer all those questions and then make a plan and address those symptoms, then you're less likely to have someone getting a pressure ulcer. So it's all about knowledge. It's about assessing your patient, planning your care, implementing, and then evaluating what you're doing. Because there's no point in having a plan if it doesn't work. So again, it's that process. Assessment, planning, implementation, and then evaluating all that you do. And of course, documenting things. This is something, and I'm not sure you're aware of, but there are different risk assessment tools out there. And this is called the Waterloo tool. And as you can see, it's quite simple to use. It's got, you assess their weight and build, whether or not they're very thin or quite large, what their skin looks like, so whether or not they've got healthy skin, if it's clammy, if it's very dry, if they've got any broken areas. You're looking at their age as well, because as we all get older, our skin changes, it gets thinner and more vulnerable. And also the males are less likely, they say, to get pressure ulcers than women. Looking at malnutrition, we've mentioned that before, very, very big thing to be mindful of. Continence, of course, if someone has urinary incontinence and or fecal incontinence, that's going to have an effect directly on the skin. It's going to make it very, very vulnerable. You can get moisture lesions, they can lead to pressure ulcers. And of course, mobility. All these things, again, for our patient with spinal cord injury, so mobility is going to be a big one as well. And special risks, this is where Waterloo is so good, because it's not just about the general things like continence or mobility, it's also things like whether or not they smoke, they're anemic, if they have any neurological, sensory, motor deficit, and also if they've had major surgery. So this is a really, really very simple assessment to use, and it's very good for any auditing that you're using, and it's evidence of your care, that you're actually assessing your patients. So again, from a risk management point of view, you do need to have a clear pressure ulcer prevention strategy. It needs to be easy to use so that you can share that knowledge and teach your staff. You really need to think about having this as a mandatory training session for all your new staff coming into your hospitals, because if they don't know, how can they prevent? All right. So it's like our friend here who, when we came into the building, one of the first things, the mandatory things, was the fire exit is that way. All right. Simple training. If we can train our staff about pressure ulcer prevention, you're not going to get a pressure ulcer. It's as simple as that. And this needs to be part of your multidisciplinary team approach. I would be talking about it, the OT would be talking about it, the physiotherapist talking about it, the doctor, the psychologist. Everyone is really, really important, because if you have someone who's in bed, not able to move, they become isolated, they become depressed, and again, you've got that vicious circle again. Avoiding pressure injury, it's about very safe, regular repositioning. So you're looking after the skin, but also you're looking after the spinal cord and the vertebra, all right? So here, and we're going to be doing positioning and manual handling during the workshop, but really, really important to get this right and work as a team. This is called the 30-degree tilt, and it's where, again, we'll be looking at this, but this is very simple to do, and it is where you use a number of pillows, you can see here. So they're slightly tilted 30 degrees. So actually, your patient is not lying or resting on bony prominences. So it's a really good position to use. Also, it means the spine is in alignment. So you're protecting that spine, you're protecting the spinal cord, and you're increasing the chance of perfusion to that injured area, okay? So really, really important. Now, the other thing for the nurses and the carers who invariably are looking after the patient, have hands-on care with the patients, the one thing we can do to help our friends, the physios and the OTs, is to prevent foot drop. And here you can see, simple. So rather, if you've got someone who has a flaccid paralysis and their feet are bent like this, all you need to do is do that, put the pillow there, and it will reduce the pressure on the joints, but also the ligaments and the tendons and the muscles. So it's a really, really simple tip, and will make the life of everyone much, much easier. Again, just looking at documentation, this is a great way to communicate to your colleagues and to your patient as evidence that you are doing turning. So it could be very simple. All you need is a time, how you're turning them, if they're on the left, their right side, supine, they could be prone, and then just sign it, and there you are, you've got your evidence that you are caring for your patient. Ultimately, pressure ulcer prevention, we want to hand that responsibility over to our patients because we want to empower them. The only way we can empower them is to teach them, okay? So we need to be sharing our knowledge not only with our staff, but with our patients, because ultimately it's their body, all right? And if they understand the implications of not moving, not looking after their skin, then they're more likely to be empowered to change position and reduce the risk of getting a pressure ulcer. So really, really important. And one of the very simple things is to check the skin. Have a mirror and check the skin twice a day. And build that into the routine, and something that you can start right from the beginning of the rehabilitation. The Waterloo pressure ulcer prevention tool has actually been translated into other languages. It is actually in French because I got it translated in French for use in Haiti, and they are using that. So please let me know if I have sent a copy of the French version to Dr. Amber and Shiva, but it is out there. It's also online. And something that you can aim towards is the 15th of November this year is World Stop Pressure Ulcer Day. This is done every year. Last year, the year before, I was in Madagascar. I was there for World Stop Pressure Ulcer Day, and it was great because we all, as a group, we created leaflets in the local languages, we went around the wards, and we gave some updated training for all the staff to show the implications of not caring for the skin and caring for the skin. Very quickly, we're going to do this a little later, I think tomorrow, on bladder and bowel care, but there are implications for the urinary systems, for the bladder and for the kidneys. And from a risk management point of view, we need to protect those kidneys because there is disruption in transmitting information after a spinal cord injury. People do lose the perception the urge to urinate, and there may be loss of voluntary control of urination. So this is a big issue. And it goes without saying, if you suspect a spinal cord injury, and as she said, catheterise. You're protecting your patient's kidneys and their bladder, because they may go for many, many, many hours with the bladder filling and filling and filling and filling. And I've seen a bladder with 2 litres. I mean, that's not good. So catheterise the patient if you suspect spinal cord injury straight away. Rule of thumb, if you're looking at neurogenic bladder, you have, as Sue was saying earlier, you have the upper and lower level injuries, and so with the bladder you're looking at round about T10, where above you've got a reflex bladder, and that's where you get this contraction of the detrusor muscle, the bladder muscle. It contracts, and then you get incontinence, and then you've got the flaccid bladder, which is below, and that's where you have the absence of contraction. So it's a little bit like blowing up a balloon. It just fills and fills and fills, and then you may well get overflow of urine. So you may think your patient is passing urine, but actually they're not. They've got a full bladder and they've got overflow. So this is why it's really, really important to know this, because again, from a risk point of view, then the kidneys may may be affected in the long term. Certainly in the UK, we do video urodynamic studies at least on a yearly basis. So I'd say the kidneys, the urine tract is very, very important, because there are risks of urine tract infection. Yeah?
We'd like to see something at this stage. With regards to there is a condition called coda equina.
Yeah.
And the problem is that people believe that when you've got the coda equina, it means that you are incontinent. At times, you're not incontinent, you're just retaining urine, and you're in retention.
That's right.
And all of a sudden, you have a few drops that come out when there's an overflow, as Fiona just says. So it's important just to bear in mind. And the second thing that I would say is that I've seen normal bladder being distended for surgery that went longer than planned, and the patient recovered from the surgery, but had a bladder problem because the detrusor muscles were stretched so much that they were irretrievable.
Yeah.
We could not get them back.
Yeah.
And the patient then became incontinent, had a problem with the bladder, just because we didn't take proper care of the bladder.
And that's what, again, it's if you suspect a spinal cord injury at whatever level, catheterise. Really important, isn't it? These are the bladder management. Again, this needs to be individualised and appropriately assessed. But what we're trying to aim for is for that person to be independent, and it may be that they have to self-intermittent catheterise for the rest of their lives to protect their bladder, protect their kidneys. And that's something I'll talk about later. Interventions, we can look at, initially the patients will have an indwelling urethral catheter, which is a Foley, but again there's a risk of urethral erosion, infection, blocking, and also of kidney stones and things like that. There's the suprapubic catheter again. People think that that is the solution, but actually there's still risks of infection, blockages, stones and whatnot. So you do need to look after the catheters very well. Bladder tapping, I don't know if that's done in Mauritius, but please don't do it, because it's where you literally just tap the bladder, and it can actually cause some involuntary muscle movement, and people can pass urine, but that has the risk of reflux going up to the kidneys, so please don't do that. As I say, the gold standard is intermittent catheterization. And I do apologise about this photograph, but I saw this on a number of occasions in Haiti. And this is this is a gentleman with a urethral erosion. There was no surgical intervention for this poor gentleman, and this was due to a urethral erosion. So this is something that we cannot allow to happen. in this day and age. And that was only in 2010, so that's only 8 years ago. Okay?
But the problem here in Mauritius, we can't get hold of so easily of
No.
the capital catheters.
But then again, it's managing. It's how do you support them in the bladder? Because as you know, the catheter is held in the bladder by a balloon, and so it's making sure that that catheter, for a gentleman, for example, you can tape it to the abdomen to take away the pressure from the bladder neck caused by the balloon, or you could tape it to the thigh for a lady. Again, it's reducing that pressure, making sure that the area is clean, you've got good hygiene, good techniques. Yeah, so it's just prevention of urinary tract infections, protecting the renal tract, avoiding erosion, and ensuring confidence. Because I have to say, is if you ask someone if they would like to walk, or if they wanted their bladder and bowel function back, they would want their bladder and bowel function back. That is the big thing for our patients. If you can support people to become continent, then you're going to be raising their self-esteem, raising their confidence, and increasing their independence. Then they'll be able to go outside, socialise, go back into you've got community reintegration, employment, and so on. So it's really important. We may take bladder and bowel care for granted, but seriously, this is really, it's so important, I cannot stress it. From the bowel management point of view, again, you have disruption of information being transmitted, you lose the perception to defecate, and you may lose the voluntary sphincter control. And rule of thumb, it's slightly lower. You're looking at L1-2 level for the bowels from an upper and lower injury. But if you've got a reflex bowel, that's above L2, you may have a spontaneous, uncontrolled defecation. And then if you have a lower level injury, then you have this flaccid, sluggish bowel. I mean, all bowels are actually going to be affected by a spinal cord injury, so you have to work with the body, certainly. Right at the beginning, you're thinking about paralytic ileus. So risk management, our patients would be nil by mouth, because when they're in spinal shock, their gut may be paralysed for a number of days. You're wanting to avoid fetal incontinence, impaction, constipation, and again, as I've mentioned before, there's isolation and depression, self-esteem, and so on. Bowel management needs to start at the beginning. What goes in has to come out. If you don't help that person, they're going to get very constipated, very uncomfortable. And I've certainly, even in England, seen people who have not had passed a bowel motion for 2 weeks, 2.5 weeks. It's shocking. It's not good at all. But anyway, the objectives, it's having patient autonomy and independence, improving the quality of life. So there are techniques. There's what's called digital stimulation, there's manual evacuation, there's transanal irrigation that we can use. Some people just need the use of suppositories, but also a very simple thing, abdominal massage, which is you massage the abdomen going ascending colon, transverse, descending. So you do it this way, and that can help. But it's also, you need to be working with your body. So you're looking at bowel management after food or after a hot drink, okay? Because when you eat, you smell the food, that may help you to salivate. You chew the food, you swallow it, and as you do that, then the peristalsis is working, okay, and pushing the food through the gut. As you know, with the small intestine, that's where the nutrients are generally absorbed. In the bowel, in the large intestine, that's where the fluid is absorbed. If you've got a very slow gut, and you're not allowing the stool to be passed, then all that fluid is going to be absorbed. So that you're going to get even more constipation, okay? So that's why you really need to make sure that the person is having a good bowel function and bowel management. Anyway, generally sort of with a higher level injury, it's digital stimulation, and that's literally with your finger in a rotating movement. Again, I'll go through this tomorrow. So that can stimulate the rectum, and the anus, and then if it's a lower level injury, then it's invariably going to be manual evacuation. From a risk management point of view, we need to know what's happening, the type of stool, the consistency, how much, the quantity, and whether or not we're using medication. And this is called the Bristol stool chart. And it helps. Everyone is talking the same language. So if you say type 1 stool, then you know it's going to be like rabbit droppings. Okay, yeah. What we want to do is aim for type 3 to type 4. Here. Okay, that's what you want to aim for with your patients with spinal cord injury. Okay. And finally. So we've thought about respirations, we've thought about moving and handling a little bit, pressure ulcer prevention, protecting the kidneys and the bladder, protecting the bowel. What about autonomic dysreflexia? Okay, so this is something that may well happen to a patient with a spinal cord injury at T6 and above, all right? Around about 80-85% may have symptoms. And this is caused by pain, or noxious stimulation, okay? So at least about 90% of people, if they get autonomic dysreflexia, okay, it's because of a full bladder, all right? What can happen is you get this sudden rise in blood pressure, you get a decrease in the heart rate, you may get goose pimples, a feeling of doom, tight chest, stuffy nose, all these symptoms. You have to act on this because it's a medical emergency, all right? So it could be a full bladder, it could be a full bowel. For a gentleman, it could be that they're sat on their testicles. It could be an ingrowing toenail, or it could be a pressure ulcer. So from a risk management point of view, when you have your patient coming in, this is why you need to know the level of injury, okay? So T6 and above. So Monsieur Louis, he's T4 Asia A, so it's whether or not you think he's at risk of autonomic dysreflexia. As I say, it can cause death, so it is a medical emergency and you need to treat it by sitting them up, take away that pain, and some people do, are treated with either GTN spray, which can lower the blood pressure, or nifedipine that they chew, they crunch. Okay. Yeah, sit up. There we go. Okay, so just keep checking. If it's not an empty, if you've emptied the bladder, you've emptied the bowel, you've checked the wound, checked the clothing, checked the scrotum, is it something else? It could actually be appendicitis or a cholecystitis. Okay, so you must keep checking until you find that, because this person could actually have a cerebral bleed and then die. All right, so it is a medical emergency. So prevention is definitely better than cure, for sure. So in conclusion, risk management, treat your patient holistically, individually. Every single system you need to go through, because they may well all be affected by the spinal cord injury. All right. Any findings, please act on them. If you don't know, please go and ask someone who does. Very, very important for the nurses to be looking at making sure that they have very regular vital signs, temperatures, blood pressure, heart rate, saturations and whatnot. Even measuring the calf and the thigh, because our patients are at risk of deep vein thrombosis. Just in closing, we have a World Spinal Cord Injury Day. It's the 5th of September every year. So maybe in Mauritius you'll be doing something on that day. It's www.worldsciday.org. So that's just plug for that one. And also, there is a grant which is going through the International Network of Spinal Cord Injury Nurses. It's about bladder and bowel studies. The closing date is the 1st of September. It's worth €2,000. So as long as you've got a nurse in your team, so it could be doctors, physios, OTs with nurses. If you want to do a study, then I'd love to see Mauritius up there and getting winning this year. So do come and talk to me about that. Merci.